Hey team, this is Alison Moe with Atlanta Gastroenterology Associates. Thanks for coming to my GHAPP MASLD Community Network. We're going to talk today about some information that we use when we're talking to these patients, and we're talking about education on metabolic associated steatotic liver disease. If you need to record your attendance for this meeting, you can go ahead and scan the QR code so that you can get your credit. So we recently were talking about diagnosing patients with advanced fibrosis who have metabolic associated steatotic liver disease. When people hear that they have F2 and then they hear that they have F3, that makes a big difference to them, because especially when I show them like the liver model and they see the difference between where F3 and F4 is, it's important for us to make sure that patients know the difference between the last stage essentially of advanced fibrosis before we get to F4 fibrosis or cirrhosis. So let's talk about a patient example here. So we have Sam. Sam is 55 years old. He's referred for mildly abnormal transaminase levels, and he's had an ultrasound of his belly that shows some increased liver echogenicity, and he's complaining of fatigue. So based on this, just as a 55-year-old Caucasian male who is with a BMI of 33, my initial instinct would be to think that he probably already has some fatty liver disease. His medical history includes some of our classic risk factors, including type 2 diabetes, hypertension, hyperlipidemia, sleep apnea. He denies any alcohol use. And on physical exam, there's nothing that looks like he has advanced liver disease. So he does not have any telangiectasias, which are little burst blood vessels on the face and the chest, very consistent with advanced liver disease. He does not have any edema, and he does not have any hepatosplenomegaly on exam. For his medications, he's taking medications for kidney issues and some high cholesterol and high blood pressure. On his routine labs, we see that his INR is normal. His secondary liver workup is essentially normal. His vital signs are stable. He's obese, but he has maybe some early medication-resistant blood pressure, but nothing that would be unbelievably alarming to me. His hemoglobin A1C is not the best I've seen, but it's not in double digits. But he does have elevated liver tests with an AST and ALT at 85 and 72. His alk phos is okay. His bilirubin is okay, but his platelets are low at 157,000. And platelets being low is a big risk factor for me that someone is going to have potentially more advanced liver disease than we initially assumed. So in this patient, I would do, and my standard for all my patients with non-invasive testing is FIB-4 score as well as a FibroScan. So his FIB-4 score is out of our normal window. It's 2.74. His FibroScan says that he has a KPA of 11, and his CAP score is 262. His ELF blood test, which is a blood test that we use sometimes as a secondary non-invasive testing, is also 9.9. And anything close to 10, we start to assume that the patient may have more severe advanced liver disease. Based on our FibroScan results alone, his KPA being at the 11 means that he has a F3 disease. And I would say that based on his platelets and based on his FIB-4, that using all of those non-invasive testings, that would be very accurate for this patient. So at this point, we have imaging that shows the hepatomegaly, but excuse me, that does not show anything other than increased echogenicity and some fatty liver. We have platelets that are low, but they're not less than 140,000, and the AASLD uses 140,000 as kind of the number that we would say means somebody may have cirrhosis. And based on his comorbidities, I think it's reasonable to say that he has F3, fibrosis stage 3, metabolic associated steatotic liver disease. In this patient, I would treat him by talking to him about two things. One, glycemic control, getting that hemoglobin A1C as good as and as better as possible, his diet choices, moving towards things like um, uh, uh, a Mediterranean diet, and then talking to him about our medical therapy that we have as far as resmetirom or Rezdiffra. So, in his in particular scenario, this considered GLP-1 therapy is something that I personally am doing in patients who have metabolic fatty liver disease, obesity, and they have diabetes. If a patient is already on diabetic therapy and that therapy is more than something like metformin, then I will have a conversation with that patient's endocrinologist or primary care team to discuss whether or not they have ever talked with the patient about GLP-1 therapy. If the patient is not on any advanced therapy for their diabetes, then in the setting of that patient having advanced fatty liver disease and being F3 with some prognostic indicators that we may advance, then I will start that patient on GLP-1 therapy. As far as monitoring for HCC, these patients normally are getting follow-up imaging that's cross-sectional imaging or imaging for um, elevated liver tests. So when we have people who are with advanced fibrosis, especially stage 3, there is some data and suggestions that those people should be monitored for HCC screening. And that's because we know that that may occur even in patients who are not cirrhotic. So now let's talk about a same exact patient, but with a different profile. So this patient is the same patient, has type 2 diabetes, hypertension, hyperlipidemia, sleep apnea, doesn't drink, on the same meds, has an obese abdomen, and has no evidence of hepatosplenomegaly. But this patient has AST and ALT that are 85 and 72, but the platelets are 128,000. Bilirubin is now 1.4 from our 1.17 patient from before. Otherwise, essentially everything is the same, including the patient's INR. This patient's non-invasive testing says that his FIB4 score is a 3.36. His KPA on the FibroScan is 21, well over the previous patient's 11. And then this patient's ELF score is 11.4, which is all based on our non-invasive testing as well as with our platelets being low, consistent with a patient having cirrhosis. So this patient, even though they do not have signs of portal hypertension on exam, based on their non-invasive testing and their platelets, that person has cirrhosis. Now, this person is not a candidate based on current FDA recommendations and medication indications for being on resmetirom therapy. This patient needs to have diet and lifestyle education, and that's critical for this patient because we don't have a medication option. He needs to be monitored for hepatocellular carcinoma with imaging every 6 months, and this patient needs to be screened for portal hypertension and esophageal varices on an EGD. So our non-invasive testing, as well as our platelet number, are two key indicative factors for patients and what they would require long-term. So just side by side, the difference for these patients with their non-invasive testing, really the ELF score and the KPA and the FIB4, even without the platelet number, are very indicative of the difference between F3 and cirrhosis patients. So the biggest difference is that one of these patients is not a candidate for resmetirom or Rezdiffra therapy. And that's because we do not have the FDA approval for patients who have cirrhosis at this point. It is important to make sure that you are paying attention to things like F3 and F4 so that you can get patients on the appropriate medical, lifestyle, etc. therapy. If I have a patient who has indeterminate non-invasive testing, so let's say I had those two patients that were exactly the same on their non-invasive testing was exactly the same, but one patient had platelets of 120 and the other patient had platelets of 160, I would probably get that patient scheduled for an endoscopy to look to see if they have signs of portal hypertension, to see if that would help me make my decision that that patient is fibrotic with cirrhosis. And then ultimately, HCC screening and surveillance is important. And we're doing it now in patients who have further advanced fibrosis, including F3. And that's because we now know that patients who have cirrhosis, no matter the stage, no matter the decompensation, as well as patients who have advanced risk factors, are at risk for developing hepatocellular carcinoma. Thanks so much for your time today, guys. If you have any questions, please feel free to reach out to my MASLD network.